Hello everyone, this is Tanbir, second year internal medicine resident from Amarillo, here to talk about a case of unexplained recurrent severe hypercalcemia in an HIV patient. This is a 60-year-old male who'd been having polyuria, polydipsia, and constipation for about a month. He also reported having a 45-pound weight loss in the 4 months leading up to the current admission, during which time he was also having night sweats. He was referred to our service from his PCP for a calcium level of 14.5 that was picked up on routine lab work. Nothing too significant on his past medical history, except for the HIV and being on treatment for it. Vitals were essentially normal, except for hypertension. Exam was basically normal as well. Just want to point out that he was oriented ×3 despite the calcium level of 14. On his neck exam, he didn't have any neck mass or palpable lymphadenopathy. On his basic labs, the CBC was notable for anemia as well as eosinophilia. And the chemistry, of course, confirmed the high calcium level and was also suggestive of an acute kidney injury. And there was a pretty notable gap between his total protein and his albumin level as well. Just want to quickly review the 3 months leading up to the current admission, because he was admitted to our service a couple of times before I saw him in July. In April, he came in with syncope. At that time, CAT scans had showed extensive mediastinal lymphadenopathy as well as numerous lesions on his spleen. By this point, he was off his HIV treatment for about 5 years. After acute stabilization, he was discharged home with some prophylactic antibiotics, which included fluconazole, as well as arrangements to restart his ART therapy. A couple of months later, in June, he was referred from his PCP's office for a calcium level of 12. After acute stabilization, he left the hospital with a plan for a splenectomy. This is his chest CT that shows pretty extensive lymphadenopathy all throughout the mediastinum, and the largest one measured about 1.1 centimeter, which would put it at that ambiguous range where there is no definitive indication for a biopsy, and the decision to obtain one was foregone since the lymphadenopathy had gone down from the previous admission. And this is his CAT scan showing his spleen, and as you can see, there are extensive lesions all throughout the spleen. Now, before we dive into the cause of this hypercalcemia, and there are a couple of clues as of right now, let's briefly review the diagnostic approach to hypercalcemia. So the first step would be to distinguish whether it's PTH dependent or not. Our patient's PTH level was 24, which is near the lower limit of normal. And after making this distinction, we need to measure PTHrP, 25-hydroxyvitamin D, as well as calcitriol. In our case, the PTHrP was negative, making malignancy less likely. And this calcitriol level, even though it's technically within the reference range, calcitriol should behave similar to PTH in hypercalcemia in that it should be suppressed. So this value of 64, which is near the upper limit of normal, would certainly be considered unusual. And with this in mind, it would put lymphoma as well as any illnesses that causes granulomas to be higher on the differential, which is why we got a quantiferon test for TB, which was negative. We got an ACE level for sarcoidosis, which was normal as well. We also got a protein electrophoresis. Remember, he had a pretty significant gamma gap, but it did not show any polyclonal gammopathy. So far, only thing that is pointing us towards a possible diagnosis is this fungitel assay, and we'll talk more about it later. So as I was alluding to in the previous slide, we now have a couple of things that are rising to the top of our differential for this PTH-independent hypercalcemia. Someone with uncontrolled HIV presenting with classic B symptoms would make you believe that it's lymphoma until proven otherwise. But then how is his mediastinal lymphadenopathy improving with antifungals? And there is also this fungitel assay that's pretty significantly positive and cannot be ignored. Fungitel is essentially the brand name for a beta-D-glucan assay, and any level greater than 80 is suggestive of invasive fungal infection. And this was indeed the case, as his coccidioides antibodies came back high, and we were able to arrange for an IR-guided splenic biopsy, which essentially showed granulomas with staining that was suggestive of a coccidioides morphology. So just to recap the management in the acute setting, you need to distinguish if it's PTH dependent or not to guide further workup. We also want to acutely stabilize the patient, and we did that in our case with IV hydration, as well as a dose of a bisphosphonate. The long term, you want to figure out what's causing this hypercalcemia in the least invasive manner possible. So our patient had that IR-guided biopsy, and he was started on appropriate dose of fluconazole after the confirmation of the fungal. So this is just reviewing the current treatment and monitoring guidelines. I just want to point out that this is a disease that is at high risk for recurrence and needs to be monitored closely for resolution. Now, I would just like to highlight some important points of discussion about coccidioidomycosis, the most important of which would be that we do live in a cocci-endemic region. I know in our textbooks, it's classically taught as a disease from the San Joaquin Valley in California or Arizona, but a picture from Palo Duro is essentially indistinguishable from a picture from the Grand Canyon because our geography and climate is so similar. It's basically that dry, arid soil. Compounding our risk is that we have an overrepresentation of occupations that would be at higher probability for contracting such a disease. And this is essentially everyone who's working in the oil and gas industry, in agriculture, or construction. This is a map of the CDC of areas assessed to have a high probability of cocci. Areas that are shaded darker orange have a higher probability, and as you can see, all of West Texas is shaded in the darkest of orange. And this is a map of all of the reported cases of cocci, and as you can see, Texas is grayed out despite being an endemic region because the disease is not reportable in our state. 60% of coccidioidomycosis cases are actually asymptomatic, so most cases never reach medical attention. But those who are at risk for having severe disease are folks with uncontrolled HIV, people with any sorts of immunosuppression, African or Filipino heritage for unclear reasons, as well as diabetes and increased age. Disseminated disease is actually seen in less than 1% of cases, and dissemination to the spleen is definitely very unusual. So finally, I've concluded from working this case that hypercalcemia in coccidioidomycosis is in fact mediated via calcitriol. And this is an important conclusion because even though it is recognized as a complication of cocci, there is no agreement in the literature as far as the mechanism behind it. It's most likely because of macrophages that both produce and activate 1-alpha hydroxylase. There is some suggestion in the literature it could be related to a transient PTH-RP elevation, but this could also be secondarily through calcitriol. Regardless, I think it's something that can be teased out pretty easily through observation and/or experimentation. Next, I think it is underappreciated that we do live in a cocci-endemic region, and we should definitely keep it more often in the back of our head as a physician practicing in West Texas, and we should certainly make it a case to make coccidioidomycosis a reportable disease in our state. And finally, I think we've been able to demonstrate that if you have a logical process for exhaustively working the differential, you can find concrete answers to puzzles no matter how confusing they are in the beginning. Thank you all for your attention.